Really appreciate it. It is Heart Month. And a lot of what we do, obviously, is reacting to heart disease in the hospital. We take care of patients at their sickest, but a lot of what we try to do in the office as well is prevent it, because there's a lot that can be done to prevent heart disease, and it's fairly simple interventions that can be done. And we'll talk a lot about that today. When I talk about heart disease, there's a lot of things that are encompassed there. The primary focus of this talk is really going to be atherosclerosis or coronary artery disease. This is the basis of heart attacks. Heart attacks happen when the arteries that feed the heart, the coronary arteries, are blocked. Blood flow can't get to the muscle dies, and that's a heart attack in general. There's a lot of things that happen thereafter, but that's the basic premise. This is a schematic that I've taken from the Cleveland Clinic, where you start to see the development of a cholesterol plaque inside the walls of an artery. And little by little, it starts to grow, and then effectively, at the moment you have a heart attack, it'll rupture, a blood clot will form, and that starves the muscle of the oxygen that it needs because the blood's not able to flow. Cholesterol is a waxy fat-like substance that the body actually needs, and it makes it. It's needed to build cells. It's in the wall of cells. It's used to make vitamins. It produces hormones. It does a lot of other things, but it is a needed substance. Too much of it, though, happens in, most people, and this is what increases risk of heart disease. Now we have good cholesterol and we have bad cholesterol. These terms are being actively studied, and some people think it's somewhat antiquated, but it is, in broad strokes, still applicable, that your high-density lipoprotein, or your HDL, is the good cholesterol, and your low-density lipoprotein, I say L for lousy, is the bad cholesterol. And these are two of the main components of the lipid panel, and something that your doctor will be following. Blood pressure is something we hear all the time, but it's specifically the amount of force that blood uses to get through the arteries and to the organs and tissues that require the nutrients within the blood. We have the top number and the bottom number. We call these the systolic and the diastolic blood pressure. Specifically, that systolic blood pressure is the pressure when the heart is beating. The pressure within the arteries after heart beats, sort of as the wave of blood that comes out of the heart is moving through the arterial system. And then we have the diastolic blood pressure, which is essentially the pressure in between. Normal blood pressure is 120/80. People talk about being in the 120s as normal, but technically that's the first stage of hypertension. We don't jump to medications there, but it is effectively hypertension if you're over 120/80. When I think about heart disease and when I think about prevention of heart disease, there's some things you can't really change. You can't really change how old you are, you can't change your gender, you can't change who your parents are, and you can't change your ethnicity. But these things are associated with your risk of heart disease. The older you are, the more risk you have. Men, certainly in younger age, have more risk. It's fair to say as women get older, and especially at postmenopause, that risk tends to become similar to men. Family history, of course, can drive a lot of risk. There's a lot of genetic factors, known and unknown, that relate to heart disease, especially in patients who come to me who have a family history of heart disease, and somebody before the age of 55 who's a man, or and somebody who before the age of 65 who's a woman. That's a high-risk finding, especially in primary relatives, mom, dad, brother, sister. But either way, that increases your risk. And then we've also seen through a lot of recent studies that some ethnicities tend to have higher rates of heart disease compared to others. South Asian, African American, Hispanic, and Latino communities jump out. However, it can happen to anybody. These are just sort of the general risk factors that we look for in general. There's some other conditions that can increase your risk. So you may have developed another chronic condition that itself puts you at higher risk. Certainly an area that's got a lot of research lately is people who have chronic inflammation for one reason or another, whether that's a chronic inflammatory disease, psoriasis, rheumatoid arthritis, lupus, but it's essentially every chronic inflammatory disease. HIV/AIDS, even in people who have good control, there's an increased risk there. Women who had a history of preeclampsia during pregnancy are at higher risk compared to women who didn't. Also, women who have premature menopause, especially before age 40, they're at higher risk. Chronic kidney disease puts patients at higher risk because if there's damage to the arteries of the kidney, it's not unreasonable to think there might be damage to the arteries within the heart. Peripheral arterial disease is the buildup of cholesterol plaques in all the arteries that go to your arms and legs and other muscles. Similarly, if there's buildup of cholesterol there, it's not unreasonable to think there may be in your heart as well, and many more. These are some of the big broad strokes that come to mind when I think of conditions that put somebody at risk. Of course, diabetes is another big one that should be mentioned. And then we get to the risk factors that are modifiable. These are things that we can do something about to some extent. And this is the basis of most preventive cardiology, and a preventive cardiology consult in general will focus upon these factors and how can we better them. And with broad strokes, similarly, it's really trying to obtain control of these metrics. With blood pressure, we talked about 120/80 being normal, but the risk really starts to go down if you can get somebody under 130/80. Hyperlipidemia is an increased blood cholesterol. Certainly that's not the only thing that factors into somebody's risk of having a heart attack, but if you can lower somebody's cholesterol, either through diet, exercise, medications, or some combination, you can lower the risk of having a heart attack. Similarly, we have advanced testing that I'll talk about a little later in this talk, like calcium scores and lipoprotein A, that try to see how bad is somebody's bad cholesterol actually. What is the risk here in this specific patient? Diabetes, we want the average of somebody's blood sugar to be on the lower side. Hemoglobin A1C is the general metric of that, so under 7% is generally considered to be a good value there. Obesity is a known risk factor for heart disease. We talk about this in cardiometabolic disease. So it's not just the heart, it's the metabolism and the whole organism altogether that puts somebody at risk. So now we're talking about diet and exercise modifications to help somebody lose weight, help them eat healthier, and that can lower the risk. Nowadays, of course, in the news, we have all the talk about the GLP-1s. These are the Ozempics, the Mounjaros, all those kind of injectable medications. There is heart benefit so far in what we're seeing, but obviously these are newer medications and more research will be done over time. Smoking, simple, quit, don't do it. And this includes vaping. It doesn't seem to be good for the heart. In fact, it seems to be very bad. Beyond just the cancer, the emphysema, all that stuff, this is a primary risk factor for heart disease, especially in younger patients. Diet, I'm going to talk a bit more about the things that you should be eating. And there's a lot of change to this. Not uncommon, somebody will come to me and they'll say, well, at one point somebody told me that eggs are bad, and then sort of as time went on, they told me this was bad, and then I was supposed to use low-fat margarine, and now we're doing olive oil, and that's all true. But there is probably more evidence than anything else that this Mediterranean-based diet is healthy. And there's other diets that can work. This isn't the end-all, be-all. But in terms of like broad strokes, a diet that is low in saturated fat, that is high in plant-based materials, that tends to be the better diet over time. And then lifestyle, this is exercise, this is reducing stress. Stress, I sort of joke, is the toughest thing to get somebody to reduce, because unless you quit your job or sort of change your dynamics, it may be difficult. But it is important to know that it is a risk factor to some extent. Exercise, both in a way to combat stress and just improve your general cardiovascular health, is important. We're not asking for much. We're asking for 30 minutes a day, 5 times a week. And even in less than that, there's benefit. So every little thing that can be done, whether that's a standing desk or walking around the office or anything along those lines, has benefit. So to dive in a little bit more about diet, and again, this is fairly broad strokes, and everybody's individual needs need to be taken into account when you're really trying to come up with a diet plan. But in general, I'm telling patients to avoid processed foods. If it can live on the counter for 2 or 3 weeks and not die or go bad, it's probably not good to put in your body. Similar, candies, sugary breakfast cereals, all this stuff sort of I grew up eating is not good for the heart, and there's a lot of data to back that up. Soda and sports drinks, super high in sugar. Obviously, people drink sports drinks when they're at peak athletic and they need the glucose in that moment. That's different than sort of having that be sort of a primary beverage that you're reaching for day in and day out. Canned meats really goes along with the processed foods and things like that. We're looking for healthy sources of protein. If we're going to eat meat products of any kind, is fish and poultry, and we're looking for the lean and unprocessed kinds. And what I tell patients is this stuff is good until we do something bad to it. If we bread it, we fry it, we do all kinds of stuff to it, it's not going to be good anymore. But the basic, simple preparation of healthy fish and protein, poultry sources is good. Trying to avoid red meats and pork, that goes along with the Mediterranean diet and what those people are eating. Is less of that, and it seems to have some benefit. Now, I get the question every now and again, what about these like impossible meats and these sort of fake plant-based meats? I'm not so certain that those are better than a well-sourced steak to some extent, but I think avoiding both is probably the best idea. Really, we're talking about plant-based sources of protein and unprocessed whole foods that you can sort of see and they look like they're supposed to look like. These are nuts, legumes, beans, farro, quinoa, all of that sort of things. That's what we're looking for here. And in general, in big broad strokes, we do prefer olive oil over butter. There's sort of a long discussion that can be had about seed oils and whether or not those are good or bad. But in general, olive oils over butter tends to prevent disease compared to not. I already talked about some of the whole grains, but this is really what you need to be looking for when you're picking out sort of the bread in the bread aisle, the whole grain, the farro, the quinoa, brown rice, all these sort of things. And then really in terms of probably the biggest bang for buck, there's plenty of nuance to some of the stuff I just said, and there's plenty of refuting evidence here and there in smaller sources. But if you can limit salt, limit alcohol, and limit added sugar, you're going to do well. So exercise, this is this infographic I took from the American Heart Association, which has a great website and a lot of patient data, heart.org. We're looking for 150 minutes of aerobic exercise, moderate intensity, a light jog, a walk uphill, taking the dog on an extended walk. These things count. And you're trying to average that out to 150 minutes per week, so roughly 30 minutes a day, 5 days a week. Now, if you want to do a little bit more, you want some more bang for your buck, 75 minutes of higher intensity competitive sports, swimming vigorously, these sort of things. That's also acceptable. And this is effectively the minimum baseline where I'll say that your exercise is optimal. Beyond this, up to 4 times beyond these recommendations has improved benefit the further you go, but you got to start somewhere. And I think this is a good, reasonable waypoint that most people can achieve if they want to. We talk about ways to lower cholesterol without medications, and I think those are really important because everybody can do them, and there's no real side effect to changing your diet to be healthier. There's no real side effects to walking around unless you hurt yourself. But sometimes, especially in my practice as a cardiologist, I have to think about when that's not enough. And who am I really thinking about medications to lower cholesterol beyond that? And in general, some red flags that would come up on somebody's medical record would be a starting bad, lousy LDL cholesterol of over 190. That's a pretty big number. That's not the total, that's the bad. Now, if you also have a bunch of other risk factors for heart disease, you smoke, your dad had a heart attack at 40, all this other sort of stuff, and your LDL is pretty high, that's also a red flag and needs to be individualized patient by patient. Everybody with diabetes, based on the current guidelines over the age of 40, should be considered for a cholesterol-lowering medication because the risk of heart disease is higher in that population and the benefit probably outweighs the risk. Then we also have the risk-enhancing test results. Calcium scores are pretty well known in this area. They're a great preventive test. You're basically looking for hardened plaque in the heart arteries in a really easy way. And if you have a calcium score that's above 0, you should be considered for cholesterol-lowering medication. Similarly, we have these advanced cholesterol tests, lipoprotein A, apolipoprotein B. It's common for doctors to check these, and if they're elevated above the range that most people are at, then considering medications beyond just a diet and exercise could be reasonable. These are all very specific, very patient to patient, so I'm definitely taking big brush strokes here, but this is some red flags that I come across every now and again. So just to talk about common cholesterol-lowering medications, just to put them out there in case you've heard of them or have any questions about them. Statins are the big group. Certainly a lot of concerns with statins because of the side effects that can be associated with them. In particular, there's muscle soreness and muscle cramping in about 10% of patients. But in terms of medications that have the longest track record of preventing heart attack and reducing the risk of repeat heart attacks, you really can't beat them in that way. Some of the most common medications are rosuvastatin or Crestor, atorvastatin or Lipitor, and then pretty much anything that ends in the suffix statin is a statin class medication. Those two I mentioned are the newer two, and they were developed in the late 90s and early 2000s, so newer in a sense. Ezetimibe is one of the older non-statin medications to lower cholesterol. It works instead of in the liver like the statins do. It works in the intestines to block the absorption of cholesterol. It does some other things, but that's the general premise of how it works. And its brand name is Zetia. Bempedoic acid is the newest kid on the block in terms of non-statins. It was specifically developed to be used in patients who can't take statins because the side effects were too extreme for them. It doesn't lower bad cholesterol quite as much as they do, but it is associated with the reduced risk of heart attacks. Then we have the sort of bigger guns, the PCSK9 inhibitors. You may or may not have heard of these. These are injectable medicines that are given every 2 weeks, usually reserved for either patients that have very high cholesterol and can't tolerate the other medicines, or people who have very high cholesterol and a lot of risk factors and the cholesterol needs to be lower. And then there's another medicine called inclisiran or Leqvio that is effectively a silencing RNA of the same receptor that the PCSK9 inhibitors attack. And its only interesting bit is that it's given twice a year instead of needing to be every few weeks. The last two, I think rarely would be prescribed by anybody other than a cardiologist or a lipid expert. But the first three, it's not unusual that someone's family doctor would consider these medications. Some facts and myths about statins. People get worried about statin medications. And the first thing that comes up a lot of times is, do they cause muscle damage? Through a number of different reasons, they do cause some muscle cramping, muscle soreness in about 10% of patients. This is known. It tends to wane the longer a patient's on it. But in terms of true muscle damage, it's rare, in the order of 1 in 100,000 in terms of serious muscle damage that would require additional treatment. Compare that to the 1 in 60 or 70 patients in whom you start a statin medication that you'll prevent a heart attack. It's an easy toss-up to make. Some people are concerned that statin medications can cause diabetes. If you Google anything, there's always sort of some concerns down the line there. And in general, in rare cases, it does increase the blood sugar a little bit. It's usually in people that are on the border of having diabetes that they'll fall into having diabetes. And the number one killer in patients with diabetes is heart attacks. This prevents heart attacks, so I don't worry about it too much. There's worry that statins damage your liver because they work at the liver to lower cholesterol. And while it's not unusual, it happens 3 to 5% of the time that markers in your blood of the liver enzymes will go up a little bit. It's usually transient and gets better over time, and it's rare that it causes any major issue with symptoms related to the liver. And there's no significant source of data to suggest that anybody has ever developed liver failure or cirrhosis specifically from statins. Also, there's concerns that statins have interactions with a lot of drugs. And in some ways, this might be some of the older statins. You couldn't take grapefruit juice. You had to be careful about all these sort of things. With the newer age medicines, it's less of a concern. So I recommend most patients to talk to their doctor and look over their medicine list and see is there anything that may come up. But these are well-tolerated medicines. They're in the top 10 prescribed medicines in the United States, and a lot of people are on them. And then the big one, in terms of what really worries people, is do statins cause dementia? I hear this every now and again. And overall, we don't know anything, don't know everything. But there's no proven link between statins and the risk of dementia. The biggest study on this comes out of Europe in the European Journal of Preventive Cardiology. They looked at 36 smaller observational trials. We're talking millions of patients when you link them all together. And in the groups of patients on a statin medication, when you compare them to similar patients off of statin medications, there were 20% less dementia in the group who was taking the medicine. So while this isn't a direct, randomized control trial to see does this equal dementia or not, to me, I would think over those millions of patients and their data that if there was a link, they would have come out here. I want to talk a little bit about calcium scoring. This is a test that's often used on a preventive basis, both in the cardiology office and sometimes in the primary care office. It's essentially just a CAT scan. It's a simple CAT scan of the chest. It's a low-dose CAT scan. The lowest dose, basically, where you can get a good picture of the heart. On the right-hand side of the screen here, you're basically taking, imagine if you sliced me straight across here and sort of flipped me up this way, you'd see halfway through my heart, and that's what you're seeing there. The coronary arteries radiate out from the top left corner of the heart there, which is the aorta, and kind of go around in a spiral fashion. And as you'll notice in the sort of 4 o'clock, 5 o'clock panel over there on the bottom right, it's a lot brighter in where those coronary arteries are. This is associated with a higher calcium score than on the top, sort of 9 o'clock, 10 o'clock look over there in the top left, where you don't see any of that. So specifically what we're looking at here in a very easy, low radiation way is, do you have buildup of plaque and cholesterol in your heart arteries? That's the premise. This isn't the end-all, be-all test for that. It's just an easy way that can be done, non-invasively. You can have plaque and buildup of cholesterol that hasn't calcified yet. You wouldn't be able to see it here. But over time, especially as people get older, the bulk of the cholesterol plaques in your heart arteries will calcify, and that allows for the value of this test. Interestingly, when you get somebody on a better diet, you get them on an exercise regimen, you put them on a medication, and you lower their cholesterol, the calcium score actually goes up over time because whatever plaques you have will calcify and stabilize and be less likely to cause a heart attack. But before you've done any of those things as sort of a baseline check, this is an excellent way to see, do I or do I not have buildup of plaque in the heart arteries? So on the left-hand side of the screen here, this is one of the key pieces of data from MESA, which is the multi-ethnicity study of atherosclerosis, which is sort of a series of trials that was done looking at calcium score and its association with heart attacks. And you'll see the light blue line kind of at the top. It's flat, and that's associated with over time, which is on the horizontal axis here, that most of those patients, near 100%, which is the top of the vertical axis there, over 5 and 10 years with a calcium score of 0 did not have heart attacks. This is coronary heart disease over that period of time. In comparison, even calcium scores 1 to 99, those lines start to diverge. More and more patients as you go along in time had heart disease and heart attacks. This isn't stratified for who got treated appropriately. This isn't stratified for a bunch of other risk factors. This is just sort of putting all of those patients, hundreds of thousands of patients essentially across time, and see, based on their initial calcium score, what happened to them. So in general, what we're trying to do is predict who's going to have heart attacks. So when they did this original trial, there was a lot of patients who wouldn't have qualified for medications, wouldn't have qualified for anything other than a pat on the back, whose calcium score was 400, 500, and the risk of a heart attack was high. That's really the power of this. Also, another test that's really come into vogue lately and I think is fantastic is something called lipoprotein A. So lipoprotein little a is a genetically inherited type of lipoprotein. So we talked about LDL, that's low-density lipoprotein, that's your standard bad cholesterol. This is another entity that looks a lot like bad cholesterol, but it's attached to this side protein, apo(a), as you can see kind of going around the LDL lipid core. And this is associated with a lot more problems. It's a lot more likely to get into heart arteries, cause problems. It's also associated with increased risk of stroke. Interestingly, it's associated with increased risk of valve disease. Nobody really fully understands why, but that's an area of active research. And it's something you test. It's a blood test. It's, I think last time I checked, it was $48 at Quest, and it's something you can check in anybody. You can't really change it. It kind of is what it is. Right now, there's medicines that are being studied that can lower it, and the outcomes of whether or not that lowers your risk of having a heart attack is unclear. But at a baseline, if you have more lipoprotein A, your risk of a heart attack is higher, and you should probably be considered for a little bit more aggressive prevention than if it's not. One thing that creates sort of a lot of confusion that is something us in the sort of cardiology community need to work on is that there's more than one unit you can check this on. So depending on which lab you go and check it on, you may have a number that would be considered high if you use the other units. So we have the milligrams per deciliter unit, which is how we measure basically all your other cholesterol particles. And an abnormal value of lipoprotein A on that is over 30, and a high value, or in the top 20%, is over 50. And then we have another unit called nanomoles per liter, where a high value is considered over 75, or an abnormal value is over 75, and a high value is over 125. So just important to, whenever you report a lipoprotein A to somebody, if you get a check somewhere else, make sure you pay attention to what units they were in, because it matters in terms of what the risk is. I think in the long term, we're probably all going to gravitate towards the nanomoles per liter unit, but that may take a decade before that's done. This was meant to be sort of like a brief overview of a lot of things I think about, how I view a patient when I'm thinking about how can I stop them from having a heart attack or stop them from having another heart attack. There's tons of nuance, patient to patient. There's tons of things, especially in diets and medications, all these things that come into play on a very patient level. But if we're doing these sort of broad strokes, trying to eat better, trying to exercise more, trying to think about like what is my risk and how often should I talk to a doctor about lowering that, then I think we're doing the right thing. And that's the whole idea of this talk today.
Thank you very much, Doctor.
Thank you all so much for coming.
Thanks for coming tonight.